Hepatocellular carcinoma is an aggressive, rapidly expanding mass that consistently challenges our most advanced therapeutics, forcing oncologists to seek new approaches. While immune checkpoint inhibitors like nivolumab and atezolizumab offer a targeted approach, they face a severe clinical bottleneck. Only 15 to 20% of patients respond to treatment, leaving the vast majority without benefit. Historically, we've attributed this high failure rate strictly to the local environment, specifically the tumor's genetic heterogeneity and an inherently suppressive tumor microenvironment that shuts down immune activity. But emerging clinical data suggests that the root cause of this localized resistance is not actually contained within the liver at all. The efficacy of these checkpoint inhibitors is heavily gated by the gut-liver axis. The microbiome manufactures the biochemical signals that shape the suppressive tumor microenvironment. To understand this, we have to look at the intimate anatomical connection between the gastrointestinal tract and the liver. They are linked by the portal circulation, a continuous, high-volume blood supply line that carries microbial signals directly from the intestines to hepatic tissues. The contents of that supply line dictate the liver's immune status. A supportive microbial community promotes immune homeostasis, while a dysbiotic or imbalanced one exports toxic disruption. This creates a striking clinical divergence. Two patients with physiologically similar liver tumors can have completely opposite responses to identical PD-1 or PD-L1 blockades. To figure out why these immunotherapies fail, we have to dissect the exact point of breakdown at the tumor itself, and then trace those suppressive signals backward, flowing down the portal vein to their origin in the gut. We start inside the tumor microenvironment. As we navigate the tissue, the local cellular conditions are hostile and sluggish. At the exact point of intervention, a PD-1 inhibitor arrives but fails to activate its target. The exhausted CD8-positive cytotoxic T cell remains dormant. This failure is physically enforced by the local accumulation of myeloid-derived suppressor cells, which block T cell function. At the same time, there is an expansion of regulatory T cells, or TRECs, which suppress any remaining cytotoxic T lymphocyte activity. These suppressive cells are not acting independently. Their dominance within the liver is maintained by a continuous stream of instructions coming from upstream. Following those instructions takes us away from the liver, tracing the blood flow in reverse down the portal vein. This chart details the portal conveyor. The portal vein delivers bacterial metabolites straight into hepatic tissues. In a healthy state, beneficial short-chain fatty acids travel along this route, entering the portal circulation and arriving at the liver. Once these short-chain fatty acids reach the liver, they are required to activate those exhausted CD8-positive T cells through the interleukin-12 pathway. A robust anti-tumor response in the liver relies entirely on the gut's ability to manufacture and ship these specific microbial metabolites. Arriving down at the gut lumen, we encounter a complex physical and chemical defense system, the intestinal barrier. This diagram maps out the local immune defense. In the upper layers, resident microbiota stimulate goblet cells to produce a protective mucus layer over the epithelial lining. Below, a dendritic cell extends to sample harmless bacteria, educating the immune system without triggering systemic inflammation. Within this protected space, commensal bacteria perform a vital metabolic transaction. They ferment dietary fiber into short-chain fatty acids. Following the pathway at the bottom, these newly minted short-chain fatty acids dictate appropriate T-cell differentiation, suppressing excessive inflammatory responses. This barrier functions as a physical shield while engineering a tolerogenic, pro-immune environment throughout the body. When this balance is disrupted, dysbiosis occurs. The microbiome loses key short-chain fatty acid-producing bacteria and beneficial species like BIF, resulting in immediate intestinal permeability. This triggers three distinct factors of systemic suppression. First is metabolic starvation. The sudden drop in short-chain fatty acid production starves the immune system, impairing the infiltration and differentiation of both CD4-positive and CD8-positive T cells. The second vector is bile acid alteration. The dysbiotic flora alter their metabolic output, converting primary bile acids into immunosuppressive secondary bile acids. The third vector is endotoxemia. The leaky gut barrier allows bacterial lipopolysaccharides, or LPS, to physically translocate from the lumen into the systemic circulation. The consequence of this leak is severe. As the LPS molecule breaches the barrier, it binds to and hyperactivates toll-like receptors. This chronic inflammatory signal directly causes a rapid spike in PD-L1 receptors on the surface of the tumor cell. Additionally, specific dysbiotic bacteria begin metabolizing tryptophan into kynerminin. This metabolite activates the aryl hydrocarbon receptor, which directly drives the expansion of those tumor-protecting regulatory T cells we saw earlier. The gut sabotages immunotherapy by flooding the liver with endotoxins and suppressive metabolites, neutralizing checkpoint inhibitors before they can even engage the tumor. With this mechanism mapped, the clinical focus shifts to prediction. Oncologists need to know how to utilize this gut-liver axis data before they administer a checkpoint inhibitor. Researchers are tracking fecal calprotectin, a non-invasive biomarker that indicates baseline gut inflammation and correlates with likely treatment resistance. Clinicians are also monitoring the AE ratio, the balance of Akkermansia to Enterobacteriaceae. On this clinical model, a high AE ratio points to a healthy barrier and predicts immunotherapy success, while a low ratio flags severe dysbiosis and likely treatment failure. Identifying these risks opens the door to intervention. Current clinical trials are testing fecal microbiota transplantation and targeted probiotics specifically designed to modulate the gut before cancer therapy begins. By identifying these microbial signatures, clinicians can accurately stratify patients, shifting from a reactive approach to proactive, data-driven treatment planning. When a prebiotic or transplant intervention succeeds, the systemic reversal is measurable. As healthy flora rapidly recolonize the surface, the intestinal epithelial barrier seals its gaps and restores its protective mucus layer. The downstream effects are immediate. Short-chain fatty acid production resumes, lipopolysaccharide translocation halts, and the portal vein delivers a clean, pro-immune signal to the liver. Back inside the tumor microenvironment, the conditions have changed. With the upstream suppressive signals removed, the PD-1 inhibitors engage, allowing the CD8-positive T cells to recognize and aggressively dismantle the tumor. Modulating the gut microbiome is a mechanistic requirement for precision immunotherapy in advanced hepatocellular carcinoma.